So I think now we can continue with the program. Professor Omar was not able to participate because of some health issues. So we should continue with the satellite symposium. So we can ask Professor Peschillo to join us.
So good morning. My name is Simone Peschillo from Rome, and today I was asked to discuss with you the opportunity to use the balloon guiding catheters and why for us this is a great new option. I will discuss about the available balloon guiding catheters that are already on the market, the fundamental principles and the clinical evidence that support the use of these devices. So nowadays we have a lot of technique that can allow us to do thrombectomy. When I started in 2014, we had only the stent. Now we have stent, aspiration, Solumbra, stent plus balloon guiding catheters, and so many other techniques. But what we need is essential femoral or radial access, microcatheters, and stent or aspiration catheters. Why flow arrest, in our opinion, but not only in our opinion, but also confirmed by literature, flow arrest is so important? Because with balloon guiding catheter, we can arrest the flow and reduce the fragmentation of the clot, and obviously we reduce also the new embolization the embolization new territories. There are a lot of papers published regarding this. And for example, in this paper, the risk of distal embolization was significantly reduced when we use balloon guiding catheters. But what are the differences in terms of type of clot? The efficacy of thrombectomy seems to depend on the type of thrombus composition. Aspiration seems to be more effective in red clots, and thrombectomy with stent and especially with balloon guided catheter is more effective with white clots. Here another paper that confirms that stent retrieving into an aspiration catheter with proximal balloon seems to be the safest method in terms of intraprocedural clot migration, and also may reduce the distal clot migration. So why balloon guided catheters are so effective? Because they can increase the odds of final successful recanalization. It can increase the odds for first pass reperfusion. You need less pass, so does it mean that you have less intraoperative risks? Is a faster procedures, and there is a 65% decline in distal emboli events, and 1.5 higher odds of good functional outcome, and around 30% of lower odds of 90 days outcomes. So, as I said before, there are a lot of devices that are already on the market from different companies. We have a quite good experience with all of them. Now we are using Embogad with good results, And what are the difference between or among these different kind of balloon-guided catheters? It depends on where is the balloon. I mean, if the balloon is coaxial, like in flow gate or in cello or in Bobby, if there is multi-lumen, so there are 4 micro balloons, like in the walrus, or if there is a dual lumen, like in the Embogard. Why we are happy using this device? Because it seems that the deflation times is more fast than is faster compared to the other balloon-guided catheters, and this is just an example of one case treated by this device. But I think the most important thing is that the trackability is very, very effective. I show you a very short video that show you that it's very easy to reach the vessel. And compared to the others device, and especially for first generation balloon-guided catheters, there is a completely different technology, and it's very smooth navigation, and also the balloon is you can see very clearly, and the efficacy of the occlusion is maximum. But what are the fundamental principles based on the use of the balloon-guided catheters? I would like to show you this paper because I think it's very interesting from a physics point of view. 2 primary factors determine how much force will be required to retrieve the clot: the impact force and the combined force of friction and adhesion between thrombus and vessel walls. So, balloon-guided catheter can reduce the pressure gradient that you need across the clot, and hence the function of an aspiration catheter. I think that is very important. And as I mentioned before, there are a lot of papers that were published during the last years, and this is one of them that show clearly that the use of balloon-guided catheter can improve the rate of early revascularization and can improve the clinical outcome. And these results comes from a large trial that was published last year. Another paper and another one published on JNIS that show you that the addition of distal aspiration catheters does not provide an higher rates of reperfusion or improved clinical outcomes. In this other paper, they clearly show you the favors in terms of the use of the balloon-guided catheters, in terms of TICI, of time of recanalization, the number of endovascular attempts, the distal emboli, symptomatic intracranial hemorrhage, and all these data support the use of balloon-guided catheter. So there are no more questions to not use these devices, and in particular here again, regarding the MRS score and the mortality show clearly the efficacy of these devices. So to summarize, balloon-guided catheter are associated with better intraoperative technical outcomes, can reduce the complication rates, and can improve the clinical outcome. And also, especially in tandem strokes, could be very useful, because during tandem occlusion, you can use the occlusion, the floor rest, to treat the carotid disease, but also, as I've shown you here, it's more easier to find the true lumen of the carotid using the balloon, because here, without the balloon-guided catheter, you cannot see the true lumen. If you arrest the flow, it's more easier to enter through the true lumen. So whatever you want to use the aspiration plus stent, or stent only. Based on published data, balloon-guided catheter seems to be more effective. And last but not least, I found this paper that I think is very interesting, that show how balloon-guided catheter could be used also during tumor embolization, just to in order to reduce the risk of reflux in ICA. To conclude, I would like to share with you this paper that summarizes the pros and cons to using the balloon-guided catheters. Of course, for everything and for every kind of device, we have pros and cons. But in our opinion, in my opinion, I think that the pros are most important compared the cons. So in conclusion, the currently available data show better results in thrombectomy, especially with stent retriever with flow arrest. Now we have the new data about these devices, and also now we have a new generation of these devices, because compared to the first generation that were very stiff, now, as I show you, it's very simple. The navigation, very straightforward procedure. There is no, so far, comparison with the super large bore catheters, so we are looking for these results. And you can use also, not only if you use normally the stent for thrombectomy, but also with Solumbra technique. And they show also good results also in tandem occlusion. And lastly, you can use it also via radial approach. So I think this is very interesting. So again, why you don't use this device? I think that is one device more in our armamentarium. So I would like to ask you, what is your experience? And lastly, I would like to use this stage, as I did yesterday, to show you what are our initiatives for training. Today we see a couple of very interesting presentations regarding the new services that needs, especially for thrombectomy service. So our idea in Rome and with ENS is to offer a comprehensive training, not only for neurosurgeons, but open to neurologists, neuroradiologists, cardiologists, vascular surgeons, wherever want to be more involved in endovascular procedures. This is, for example, the European Neurovascular and Endovascular Training Center. We have scheduled a lot of training session for hybrid, endovascular, and open vascular training. In May, we will have the chronic subdural hematoma course in Rome. We are going to organize the SNAC at the end of October, also in Rome. And this is the basic course, I think, for someone who wants to be more involved in endovascular, because we are going to discuss and to present the neurovascular anatomy from a surgical point of view and from an angiographic point of view. Last but not least, the European Master Program, where if you want to be trained for 1 year fellowship program across Europe, we have 14 centers across Europe. And here in Sofia, we have Dr. Arliowski Center that will host this master. And this is practical master. So you have to be involved in the practical activities in the angio suite or in OR. Thank you so much.
Thank you. Is there any questions or comments coming from the room?